Vitalme is happy to have Dr. Giriraja sir from MVJ Medical College, Bengaluru as our teacher and mentor today. A warm welcome to you, sir. And
Yes, good evening.
we are also glad that Dr. Priyanka, second year MD General Medicine from MVJ Medical College, Bengaluru, has volunteered to present a case today in our platform. Welcome to you also, Doctor. And we also welcome all the participants who have joined us via Zoom and YouTube. Without further ado, with the permission of the mentor, we can start the session.
Yeah, we can start. Priyanka, you can start the discussion.
Here is a case of 40-year-old female patient who is named XYZ and who is a daily laborer by occupation, hailing from Gulbarga and who has studied up to 5th standard. A patient presented with the chief complaints of breathlessness on exertion since 1 year.
So the chief complaint was breathlessness since 1 year. That is the only complaint.
Yes, sir.
Okay,
and
right.
Coming to history of presenting illness, patient was apparently normal 1 year back when she developed breathlessness on exertion, which was insidious in onset, gradually progressive from NYHA 2 to NYHA 3 during last 3 months. This breathlessness aggravated on walking, climbing stairs, and relieved on standing still and on sitting. And it was associated with history of easy fatigability. Breathlessness was not associated with orthopnea, PND, V's, platypnea, or orthodeoxia. And there was no history of any diurnal variation of breathlessness.
Yeah, so here you elaborated the history of presenting complaint breathlessness. It was insidious in onset, you are telling. Okay. Can you tell some causes where a patient will come to casualty with the sudden onset of breathlessness?
The sudden onset of breathlessness, cardiac causes, it can be acute pulmonary edema.
Yes.
Then pulmonary thromboembolism.
Yes. Which respiratory cause sudden onset of breath?
Yes, sir. Acute exacerbation of COPD.
Bronchial asthma.
Bronchial asthma.
Then any pleural disease, sudden onset of breathlessness, they'll come to casualty.
Yes, sir.
Which pleural disease?
Pneumothorax.
Tension pneumothorax.
Tension pneumothorax.
So if they come with sudden onset of breathlessness, you will consider those causes. But here you are telling is it insidious onset. And you are telling it is you are graded according to NYHA grade 2 to grade 3. It progressed over last 3 months. Can you grade NYHA classification of breathlessness?
Sir, NYHA is basically classified into 4 grades, sir. Grade 1 is there is no symptoms on activity. And then grade 2, even with minimal activity, patient experiences symptoms. And then next is severe limitation in day-to-day activities. Grade 4 is breathlessness at rest.
Orthopnea is grade 4. Okay, and you asked here the history of orthopnea and PND. That history is very important in any patient who comes with breathlessness.
Yes,
why that history orthopnea PND is very important whenever you evaluate a patient with breathlessness. Why that symptom is important, orthopnea PND?
So that symptom differentiates respiratory illness from cardiac illness.
Yes.
Whenever so patient is
that differentiate very important respiratory from the cardiac illness. If orthopnea and PND is there, which side of the heart is failed?
Left side of the heart is failed.
Left heart failed.
In case left heart failure, yes, sir.
Okay. Can you explain the mechanism of orthopnea?
Sir, orthopnea basically when patient is assuming recumbent position, there is increased venous return and redistribution of blood flow to the lungs where there is pulmonary congestion.
Yeah, from the interstitial space, the interstitial space, whenever in the day-to-day activity, blood is more in the interstitial space. So evening when they go to the recumbent position from interstitial space, the blood will go to the intravascular space. As you told, there will be pulmonary congestion. That is one mechanism. Then
the other mechanism is elevated diaphragm.
Yes, elevated diaphragm will produce a reduced vital capacity. Yes. These two mechanisms are the cause of orthopnea. What is the mechanism of PND?
Sir, mechanism of PND is also similar, and then
correct. These two mechanisms also will act in PND. Same what you
in
told
addition
the blood
to that.
Yes. In addition to that, what are the two mechanisms? During respiratory, during sleep, There is a decreased
There is
catecholamine
decreased
support,
sympathetic
support to
drive,
the
and then
left
the
ventricle.
respiratory center also is not so,
Responsive.
responsive during sleep.
During sleep, respiratory center is less responsive to hypoxia and hypercarbia, and less sympathetic support to the heart. These two extra mechanisms will act in PND. PND can occur at any stage, stage 2, 3, any stage it can occur. Here you ask history of platypnea and orthodexia. Where you get platypnea? What do you mean by platypnea or orthodexia?
The platypnea is breathlessness when the patient is sitting upright and breathlessness gets relieved on the supine position.
Opposite of orthopnea.
Opposite of orthopnea.
Orthodexia?
The orthodexia is like desaturation during sitting position and standing position.
Standing position. Orthodexia. Can you tell the disease where you get platypnea and orthodexia?
The hepatopulmonary syndrome can have both the platypnea and orthodexia, and sometimes patients with patent foramen ovale can also present with these symptoms.
Okay, right. Anyhow, so once we discuss this case, in the end, we'll come to know why this cystic platypnea orthodexia may be relevant in this case.
Yes, sir.
Yeah, you ask no history of diurnal variation. Where you get nocturnal breathlessness, which diseases?
Sir, bronchial asthma can have nocturnal breathlessness. And then patient with GERD can also sometimes they give nocturnal breathlessness history.
Okay, because of aspiration you are telling. Okay, right. Go ahead.
A history of fever 3 months back, which was present for 8 days, which was sudden onset, high grade, intermittent type, relieved on medications, and then no aggravating factors. Then history of cough with expectoration 3 months back, which was present for 8 days. Sputum was yellowish, moderate in amount, non-foul smelling, non-blood tinged, and aggravated with fever spike, relieved by medications. This was not associated with any history of sore throat, wheeze, diurnal or postural variation.
Yeah,
Then
so here this episode, you are told 3 months back he had a fever with cough with expectoration.
Yes,
3 months back, it lasted for 8 days. So probably this one respiratory infection he had at that time, the 3 months back. So this is one incidental finding probably in this case. He had one respiratory tract infection. Okay, and it relieved with the medication. Okay, go ahead.
Then history of abdominal discomfort since 3 days, 3 months, which was involving right upper abdomen, which was insidious in onset, non-progressive, and not associated with food intake, vomiting, or loose stools, or jaundice.
Yeah. What do you think the cause for abdominal discomfort in this patient? Go back one slide before.
Sir, in this patient, it can be due to hepatic congestion because of the heart failure.
So you are thinking a patient is in a congestive cardiac failure. If it is there, the hepatic congestion may be producing a right hypochondrial discomfort.
Yes.
Okay. Okay.
Then there was no history of any lower limb swelling, no history of palpitations, chest pain, or syncope, no history of cough or fever at present, and no history of cyanosis. Then patient visited a local hospital for the above complaints, where she was diagnosed with cardiac disease and referred to higher center.
Okay, so when the patient had that history of fever, at that time, incidentally, they detected patient is having some cardiac disease, and then they referred to the higher center. Okay, so but before that fever, only patient had a breathlessness since 1 year, insidious onset and progressive gradually.
Yes.
Okay.
Then coming to past history, there were no history of similar complaints in the past, no history of hypertension or diabetes mellitus, and no past history which is suggestive of rheumatic fever, bronchial asthma, tuberculosis, thyroid disorder, and history of recurrent respiratory tract infections was present in this patient.
Yeah, so you made that statement, history of recurrent respiratory tract infection. What is the definition of recurrent respiratory tract infection?
The recurrent respiratory tract infection means the patient is having tonsillitis or pharyngitis for more than 3 episodes per year, and otitis media more than 4 episodes in a year, and rhinitis more than 5 episodes in a year.
Yeah, so all the 3 constitute recurrent respiratory tract infection. 5 rhinitis or 4 the otitis media in 6 months, and then 3 pharyngitis in 1 year. So if this symptom is there, that suggests what cardiac lesions?
Sir, any left to right shunt can present with these symptoms like VSD, ASD, and PDA.
Yeah, so they can present with this history of recurrent respiratory tract infection. Okay, good. Continue.
Coming to personal history, patient consumes a mixed diet, appetite is normal, bowel and bladder are regular, sleep is adequate, no addictive habits, and no history of any high-risk behavior.
So personal history is nothing significant. Okay.
In coming to family history, no history of similar complaints in the family members. Menstrual history, history of irregular menstruation since 2 years, 3 to 5 month cycle, and with 2 to 3 days of flow, not associated with any clots.
Probably she is approaching the menopause. That's why that irregular menses since 2 years. She may be having that. Okay.
In obstetric history, 2 male children delivered by a normal vaginal delivery, and the patient was tubectomized 15 years back.
So this is uneventful. She didn't have any, though the breathlessness was present since last 1 year, but during her pregnancy, she never had any problem. It was uneventful, the deliveries. Okay.
On general physical examination.
Yeah, so before going to general physical examination, you go back one slide before.
Yes, sir.
Yeah, so at the end of history, you have to give some differential diagnosis in this case. 1 year history of insidious onset of breathlessness, 40-year-old female. Okay, so what are the DDs you are thinking with history of recurrent respiratory tract infections? What DDs you can think one by one common in our Indian country?
Sir, considering the age of the patient and gender of the patient, first thing is anemia with cardiac failure.
In India, you want to consider anemia because of malnutrition. Anemia and heart failure. Okay. And then
next thing could be valvular heart disease secondary to rheumatic etiology.
So in India, rheumatic disease is still more prevalent. It is hyper endemic area. So, but here there is no past history of rheumatic fever. How many will give history of rheumatic fever? In established rheumatic heart disease, all will give history of rheumatic fever. Only 50% will give history of 50%. 50%. Rest they won't give the history only. Okay. So, but still, so you can consider rheumatic heart disease. Which valvular disease can come in breathlessness?
Sir, both mitral regurgitation and mitral stenosis can present with the breathlessness.
Aortic stenosis, how they will come?
Aortic stenosis will present with chest pain, syncopal attacks, and then
syncope and exertion will be the predominant symptom in aortic stenosis. Okay.
Yes,
so anyhow, so rheumatic heart disease, second etiology you want to put. The third?
So third can be ischemic heart disease secondary to DCM.
Cardiomyopathy, ischemic cardiomyopathy.
Yes, sir.
Present with breathlessness. But anyhow, there is no risk factors, not a diabetic, not hypertensive. She's still menstruating. So that should be the third you want to put. Ischemic cardiomyopathy. Okay. Then?
So fourth one could be like cardiomyopathy due to thyrotoxicosis.
No weight loss history. There is no weight loss history. No other symptoms of thyrotoxicosis. No palpitation, sweating, weight loss history is not there. If that history was there, you could have thought of a thyrotoxicosis induced cardiomyopathy.
Yes.
Okay. Then?
Sir, any adult presentation of congenital heart disease because of the history of a recurrent history of recurrent respiratory tract infection. I'm thinking of left shunt lesion.
Okay, right. So history of recurrent respiratory tract infection is there. You want to think a congenital heart disease. Which congenital heart disease will come with like this breathlessness in 4 decades?
Atrial septal defect can present like 3rd to 4th decade.
They present like what? ASD in 4 decades. Usually common presentation.
Usually they present with arrhythmias.
Arrhythmias, atrial arrhythmias.
Most commonly atrial fibrillation.
Atrial fibrillation, arrhythmias they present. If they develop pulmonary hypertension, then they can have the breathlessness. Then even VST, depending upon the size, they can come with 4 decades with the breathlessness. VST. Even PDA, depending upon the size, they can present with breathlessness. Okay, so you want to put that as the diagnosis because there is repeated respiratory tract infection. Okay. Go ahead.
So next. Okay.
So with this background, you want to examine the patient with these DDs.
Yes, sir.
Examine.
On general physical examination, here is a 40-year-old female patient who is conscious, cooperative, moderately built and nourished. Pallor is present, no icterus, cyanosis, clubbing, lymphadenopathy or edema.
Okay, so that's pallor. Okay.
Yes, sir. Pulse rate 88 beats per minute, which is regular, normal in volume and character, and there is no radioradial or radiofemoral delay. vessel wall is normal, and all peripheral pulses are felt.
Okay.
Blood pressure in left arm on supine position is 128/80 mm of Hg, and in right arm on supine position 130/80 mm of Hg, and 140/80 mm of Hg in left leg in supine position.
Yeah, in which congenital heart disease upper limb BP will be more than lower limb BP?
Sir, coarctation of aorta.
Yeah, in coagulation of aorta, upper limb BP will be more than the lower limb BP. Okay.
Yes, sir. A respiratory rate is 22 cycles per minute, which is regular, and thoraco-abdominal breathing. JVP is not raised, and hepatojugular reflex is 3 centimeter above the clavicle.
Okay, so you mentioned about hepatojugular reflex, a positive finding 3 centimeter above the clavicle. Okay, can you tell a few points about hepatojugular reflex? Here you get a positive finding. Where you get, how do you do that? What is the relevance?
The procedure is patient has to be in supine position with 45-degree angulation of the neck, and then the examiner has to stand on the right side of the patient and give a firm pressure in the right hypochondrial region for about 10 seconds. And there will be a transient elevation of jugular venous pressure.
Yeah, in normally also
and,
it will rise, but it will rise less than how many centimeter? Normal
less
person
than 3
also?
centimeter.
And even if you continues to exert the pressure, it will come down in normal people.
Yes, sir.
But if there is a continuation of the elevation,
reflex is positive, for more than 15 seconds, the rise in JVP will sustain.
It indicates what?
It indicates right-sided heart failure.
Or even left congestive cardiac failure.
Congestive cardiac failure.
Okay. Where it is absent? Hepatojugular reflex. So you are pressing on the right upper chondric. The pressure is dissipated to the superior vena cava.
Okay, the SVC obstruction can present.
Buchieri. Buchieri is not absent.
Yes.
Okay. Okay, continue.
On head-to-toe examination, there are no significant findings. In cardiovascular system examination, on inspection, chest wall is bilaterally symmetrical in shape. There is no precordial bulge. Trachea appears central. Apical impulse is not visible, and no engorged or visible pulsations. No scars on chest or chest wall deformities.
Okay, in the inspection, you have not got any positive findings. So everything appears normal. Okay.
On palpation, trachea is central. Apical impulse is present in the left fifth intercostal space in mid-clavicular line, and it is diffuse and tapping in nature. Parasternal heave of grade 1 is present, and there are no palpable thrills.
But here there is a slight discrepancy. Go back to the one slide before. If it is a tap, it will be usually localized. It won't be diffuse. Diffuse usually you get in a regurgitation lesions like mitral regurgitation, aortic regurgitation in two spaces. So tapping you get in a mitral stenosis, it will be localized. It won't be diffuse.
Okay.
So there is some discrepancy there. Okay. And there is a parasternal heave you are telling 1+.
Yes,
and no palpable thrill. Okay.
On percussion, dull note is present in left second intercostal space.
Yeah, so this is superficial cardiac dullness. You have to do lightly the percussion in the left, second, third space. Normally, the cardiac dullness present in which space?
Left third intercostal space.
Third space. If it is in second space, what are the conditions?
Sir, we have to think of any condition causing pulmonary hypertension.
And any fluid in the pericardium? Pericardial
yes,
effusion.
Sir, pericardial effusion.
Okay. So pericardial effusion and pulmonary hypertension, you will get a dull note in the second intercostal space. You will do only light percussion here, superficial cardiac percussion. Okay,
sir.
So here you got two findings for pulmonary hypertension. One parasternal heave you are telling.
Yes, sir.
Then percussion dull note in second
space.
And hepatojugular reflex positive.
Yes,
so
sir.
3 findings you have got. Okay.
On auscultation in the mitral area, S1 is normal with no added sounds or murmurs. In tricuspid area, S1 is normal, low-pitched diastolic murmur, which is of grade 3, which is heard best with the bell of the stethoscope during inspiration. In pulmonary area, P2 is normal, wide and fixed split of S2 is present. And grade 3 systolic murmur, which is best heard in sitting and leaning forward position, is present. Aortic area, A2 is normal.
Yeah, so till now you didn't get, apart from the pulmonary hypertension, in your examination, you didn't get any findings to suggest to clinch the diagnosis. But in auscultation, the two important findings you have got. One in pulmonary area, you are getting a wide and fixed split of S2. That is one the salient feature. Another is a systolic murmur in a pulmonary area.
Pulmonary area, yes.
If you get a finding like this, wide and fixed split of S2, that clinches the diagnosis of what lesions?
Atrial septal defect.
It's a hallmark of atrial septal defect, wide and fixed split of S2.
Yes.
Can you explain why you get a wide S2 in atrial
Sir,
septal?
wide is because of RV ejection is delayed and there is a delayed closure of pulmonary valves.
The pulmonary capacitance is increased.
Increased, yes, sir.
More blood is entering from LA to RA, RA to RB, so capacitance increased. That's why it is closing late. That's why it's wide.
Wide, yes, sir.
Why it is fixed? Fixed. See, normal during inspiration, A to P2 will widen.
Yes, sir.
During inspiration, that is a normal phenomenon. But here it doesn't occur. Why?
Sir, because right ventricle is already full of blood and it can accommodate no more blood.
Correct. So already it is at a full capacity. No more blood can accommodate during the inspiration. That's why it is fixed. So this almost auscultatory finding is a feature of ASD.
Yes,
if they develop pulmonary hypertension, what will happen with the split?
If pulmonary hypertension develops, reverse.
It will become narrow. Now, whatever the wide and fixed split, that becomes narrow if they develop pulmonary hypertension. Okay. And you've got a murmur here in the pulmonary area, grade 3 systolic murmur. Okay. Yes, why you get this murmur?
Sir, it is a flow murmur due to increased blood flow across the pulmonary vessels.
Correct. Okay. Now there is a ASD between LA to RA. So whether you get a murmur at that area?
In the there we don't get a murmur, sir.
Why?
Because the pressure gradient between
there is no gradient. There is no gradient there. That's why you won't get a murmur across the defect. Only because of increased blood flow across the pulmonary valve, you get a murmur. Okay, right. So this clinches the diagnosis in doing auscultation. Okay. So now with this diagnosis of clinching the diagnosis of ASD, we'll review the history again from the history. What all we could have asked, what all we could have interpreted. Okay. Yes, can you go back from the first slide? Yeah, first slide. Yeah. So here you're written the sex is female. And before going to the discussion of these slides, can you tell what are the types of ASDs?
Sir, 4 types of ASD, of which ostium secundum ASD is the most common type. Then comes ostium primum ASD, then sinus venosus ASD, and then the least common is coronary sinus ASD.
Okay, right, nice. So your written here sex is female, no? Can you tell the sex importance in ASD?
Sir, in the case of ostium secundum ASD, it is more common in females than males with a ratio of 2:1. And if it is ostium secundum ASD, the incidence is almost equal, where male is equal to female.
Sinus venosus ASD and ostium primum. Yes. Sinus venosus ASD and ostium primum ASD, male is equal to females. Whereas the ostium secundum ASD, female is to male is 2:1.
Yes.
Okay. Next come. Yeah. So breathlessness. As ASD, as we discussed, they come with tachycardia, the palpitation in the 4th decade. If they develop pulmonary hypertension, they can have the breathlessness. Breathlessness. Okay. Next slide. Yeah. Next slide. Yeah. So here one attack of respiratory tract infection is having. And in the history also, you told there is a past history of repeated respiratory tract infection, which goes in favor of left to right shunt.
Left to right shunt, yes.
Yeah. Next slide. You written here, then a physical examination, no history of cyanosis. ASD is a left to right shunt. Okay. Yes, it's the acyanotic congenital heart disease. Which are the acyanotic congenital heart disease, you know?
Sir, acyanotic congenital heart disease with left to right shunt, we have VSD, ASD, and then PDA. And then total anomalous pulmonary.
No, that is cyanotic. Total anomalous pulmonary connection is cyanotic. The cyanotic heart disease. Now here in the ASD is the acyanotic heart disease. If you get cyanosis, then what do you think in ASD?
Sir, development of pulmonary hypertension.
Not only pulmonary hypertension, it should be so severe that there should be right to left shunt.
Yes, sir.
Okay, that should be right to left shunt. Okay, that is one condition. Which are the other condition you get cyanosis?
Sir, then common atrium.
Common atrium means both LA and RA single chamber, no
Single
septum
chamber.
at all. Okay,
Yes, sir.
correct then.
So then unroofed coronary sinus.
Okay, then
Patent eustachian tube through
persistent eustachian.
persistent eustachian tube through patent
What it will
foramen.
do? What it will do? Persistent eustachian tube. It will channel the blood to the LA.
Yes, sir.
Okay, so the venous blood will go to the LA, left atria. That's how you get a cyanosis. Okay, so this is one important question they'll ask if you get a case of ASD. If you get a cyanosis, what are the conditions you will think that?
Okay, sir.
Okay. Go next slide. Yeah, so past history of rheumatic fever you asked. History of recurrent respiratory tract infection we discussed. Okay,
Yes.
next slide. Personal history, nothing significant. Okay, and body mass index. How relevant here in atrial septal defect? Body mass index.
Sir, in ASD, there is a thing called gracile habitus, where weight of the patient will be more affected than the height.
Okay, they'll be thin and gracile.
Thin and gracile, yes, sir.
Okay, next slide. Family history. So usually it is a sporadic disease ASD. And the family history is usually not seen, but there are some scenario where family history is seen. Can you tell where you get a family history relevance in atrial septal defect?
Sir, mutation in NKX 2.5 gene, and then
Any syndrome?
Holt-Oram syndrome.
It is autosomal dominant. Any other syndrome?
Yes, Axenfeld-Rogers syndrome.
Yeah, that is also autosomal dominant.
Yes,
okay, and there are some familial ostium secundum ASDs also with conduction blocks.
Yes.
Okay, in these cases it will be relevant, or if it is a sporadic disease maybe. Okay, right. Next. No, you have to go back one slide. Yeah, here obstetric history is important. You mentioned now. Usually pregnancy and ASD. How whether it is well tolerated or it becomes eventful.
Sir, ASD is well tolerated in pregnancy.
Correct. It is well tolerated in pregnancy. Yes.
Yes, sir.
Okay. Right. Okay. Go next slide. Yeah. So in a general physical examination, in a case of ASD, you have to see some features because some of the syndromes are associated with the ASD. Okay, so can you tell which are the symptoms associated with some salient features with your slides, whatever you have put down?
Sir, this can be associated with Down syndrome,
come.
Where the patient will have a flat
moon-like
faces.
Slow. First is Down syndrome. Okay, so Down syndrome, which ASD is more common in Down syndrome?
Sir, ostium primum ASD is common.
That is very important. Ostium primum ASD in Down syndrome. Can you tell some important features of Down syndrome?
Sir, broad flat face, which is like moon-like faces, and then prominent epicanthal folds, then widely spaced toes, and simian palmar crease. And coming to palate, they will have a high arched palate. And then growth failure and mental retardation can be associated. Along with that, unilateral or bilateral absence of one rib can be present. And low set ears.
Yes. So what you remember is it is usually associated with the ostium primum ASD.
Primum ASD, yes.
Okay. Which are other syndromes?
Sir, Edwards syndrome, which is trisomy 18. In this, prominent features being occiput will be prominent, and then they can have rocker bottom foot with clenched hands and overlapping fingers. Then small mouth with small jaw, and microcephaly or holoprosencephaly can be there.
Holoprosencephaly means the forebrain won't divide. It will be a single brain. It won't divide into right and left lobes, frontal lobes. That is holoprosencephaly. Okay, correct. Good. Then
shield-like chest with widely spaced nipples, and then short and prominent sternum can be seen.
Good.
Next is trisomy 13 or Patau syndrome. In this, it can be associated with cleft lip, cleft palate, then polydactyly, and then dysplastic or malformed ears with undescended or normal testis.
Okay.
Then other syndromes which can be associated are Axenfeld-Rogers syndrome.
What are the features there? Axenfeld-Rogers syndrome.
Multiple frenulae can be seen.
No. That is Ellis van Creveld. The Axenfeld-Rogers is glaucoma.
Glaucoma, umbilical hernia. umbilical
hypospadias.
hernia, hypospadias.
And micrognathia, axonal Roger. Okay, it's autosomal dominant. Then this common atrium will be associated with Ellis-Van-Creveld syndrome.
Yes,
Can you
sir.
tell some features of that?
Sir, in that multiple frenulae, polydactyly, syndactyly, or clinodactyly can be seen. And then
the incisor tooth, the molar incisor teeth will be prematurely it will come, and they'll have gum hypertrophy, and the nail will be hypoplastic. The nails,
hypoplastic nails. Yes.
Okay, Ellis-Van-Creveld syndrome. Okay, yeah. So these are the some symptoms which you have to look in a case of atrial septal defect. Okay.
Yes, sir.
Now you go back to the pulse and other things. Yeah. Go back to pulse.
Yes. Pulse 88 beats per minute, regular, normal in volume and character, no radial or radiofemoral delay. Vessel was normal, and all peripheral pulses are felt.
Yeah. So in a ASD, what will be the pulse?
The pulse will be normal in a case of ASD.
Yeah, in ASD, even though the cardiac output is less, okay, because blood is going from left atrium to right atrium to right ventricle. Left ventricle is less blood. In spite of that, the pulse will be normal. Okay. Then go to next slide. Yeah, JVP. What will be the JVP in atrial septal defect? Sir,
in atrial septal defect, JVP is usually normal unless the patient developed pulmonary hypertension, where prominent A wave can be seen if the patient has pulmonary hypertension.
Yeah. So then only you get a rise JVP, or JVP will be normal.
Yes.
Okay. Next slide. So today examination we discussed. Next.
Yes, sir.
Yeah, inspection. So inspection, suppose if ASD is present, what positive findings you expect here in ASD?
Sir, if there is any precordial bulge, we can think of RV hypertrophy even before puberty.
Yes. So RV hypertrophy before the onset of puberty, you will get a precordial bulge. That positive findings you may get in an inspection.
Yes,
okay, correct. Then next slide. Palpation. Okay. So in a atrial septal defect, what are the positive palpatory findings you get?
A parasternal heave can be present, sir. That is because of pulmonary hypertension.
No, before that, suppose usually there is a atrial septal defect between left to right atrium. That defect septum is defect.
Yes, sir.
Through the defect, whether you get any thrill there because of the defect?
Sir, if we get a thrill, it means it is a large ASD. Otherwise, it is associated with any pulmonary stenosis.
Because
normally it will not be associated
because
with
there is no gradient, you won't get a thrill.
Yes.
If thrill is there, either you have to think associated pulmonary stenosis or a very large ASD. Then only you get a thrill in the pulmonary area. Or you won't get a thrill. Because the more blood flow across the pulmonary trunk, you may get a dilated pulmonary trunk in second intercostal space here. And apex beat here is RV or LV type.
Sir, it is a RV predominant apex.
It is RV because the blood from left atrium to right atrium, right atrium to right ventricle, it's RV type of apical impulse.
Yes, sir.
Okay. So these are the important palpatory things. One is RV apical impulse, pulmonary trunk pulsations may be seen. Another is if you get a thrill, that thrill indicates associated PS or a very large,
ASD. Yes.
Good. Next. Percussion here you got a dull node that indicates pulmonary hypertension. Yeah, auscultation we discussed already, the wide and fixed split, the mechanism of
and the flow murmur. Yes,
and the flow murmur occurs a pulmonary valve. These two are the hallmark of atrial septal defect. Okay, auscultatory signs. Yeah. After the auscultation, with this analysis of the history, you summarize and tell the diagnosis.
Yes, sir. 40-year-old female patient with chronic history of exertional breathlessness and recurrent respiratory tract infections with wide and fixed split of S2 and ejection systolic murmur of grade 3 is diagnosed as atrial septal defect with pulmonary hypertension in sinus rhythm with no evidence of infective endocarditis.
Okay. So in your vital examination, you have to look for a temperature. Any cardiac disease patient, if fever is there, you have to suspect infective endocarditis.
Infective endocarditis. Yes, sir.
What is your idea of infective endocarditis in ASD?
Sir, infective endocarditis is rare in ASD. If at all it occurs, it is commonly seen in ostium primum ASD, which will be associated with MR.
Because of that only you get it. Okay, nice. Okay. So, with the clinical history and analysis, you are diagnosed as a ASD. Now, how do you proceed with the basic investigations? First, what do you want to do?
Sir, ECG.
Yeah, tell the ECG findings and explain.
Yes, sir. This is the ECG picture showing ostium primum ASD, where it can have left axis deviation along with right bundle branch block.
No. Here, what is the axis here? Lead 1 is negative, AVF is positive. So, what is the axis? It's the
Lead
right
1
axis.
is negative, right axis, sir.
AVF is positive, lead 1 is negative. It's the right axis. And there is, first we have to see a V1 in ASD, whether RBB is there or not. Here RBB is there. You can
RS R dash in V1, RBB is there.
So RBB is a must.
Yes,
whether primum or secondary or secondum ASD, RBB is a must.
Okay, sir.
So RBB with right axis deviation, you get in ostium secondum ASD.
Okay, sir.
Okay. That is RBB with left axis deviation, you get in a ostium primum
Ostium
ASD.
primum ASD.
Why you get that left axis deviation in ostium primum ASD?
Sir, because it can be associated with left anterior fascicular block. So
because the defect is endocardial cushion defect, no?
Yes,
so
sir.
that left anterior fascicular block defect. That's why you get a left axis deviation because of LAH.
Yes,
okay.
sir.
Yeah. So whether really bundle branch block will be there in ASD? Or it's a misnomer? It's a misnomer. There is no block as such. Here there is a conduction delay. Why conduction delay occurs is RV is enlarged. Blood from LA to RA will come, RA to RV. RV will get enlarged. So the time taken by the impulse to conduct is delayed. That's why you get a incomplete RBB, not a complete RBB, incomplete RBB. So it is not a block here. It's a misnomer. Okay. So what are the other ECG findings? This is a hallmark. You have to tell in the exam. RBB with right axis deviation.
Right axis deviation in ostium primum.
So left axis in ostium primum. Left axis deviation in ostium primum. Because LAHB, no?
Yes, sir.
LAHB, that is the left axis deviation in ostium primum. Right axis in ostium secondum.
Ostium secondum. So in case of sinus venosus ASD, there can be inverted P waves in lead 2-3 AVF.
Correct. Why you get like that? Inverted P waves in lead 2-3 AVF?
Because SA node will be affected. So P wave will be inverted or absent.
No. SA node is affected, correct. But it will get activated by the ectopic impulse. Somewhere from the down, retrograde. That's why you get an inverted P waves. Okay. Because sinus venosus ASD at the junction of superior vena cava and SA node only, there will be a defect.
Yes, sir.
That's why you won't get a proper P wave there. It will get activated by the ectopic P wave somewhere from the lower down. That's why you get an inverted P wave in lead 2-3 AVF. What are the other ECG findings?
So this classical croquetage pattern can be seen in ostium secondum ASD, where
so
it is a needle shape.
Needle shape deflection. You can your mark there in lead 2-3 AVF, the croquetage sign in ostium secondum ASD. In ostium primum ASD, you get a splintering of the S waves. Okay, in 2-3 AVF. What will happen to sinus arrhythmia in ASD?
So that loss of sinus arrhythmia will be there. Variation of rhythm during inspiration and expiration. There will be loss of sinus arrhythmia.
Yeah, normally during inspiration, pulse rate will increase, heart rate will increase. That will be lost here. Why? Why it get lost in ASD? For sinus arrhythmia to occur, you need a separate system, pulmonary circulation, systemic circulation. But here there is a mixture, no? There's no separate system because the septal defect, both systems are clubbed. That's why you lose the sinus arrhythmia here. Okay, then the depolarization will be clockwise in ostium secondum ASD with a Q wave in 2-3 AVF, whereas counterclockwise in ostium primum ASD with a Q wave in lead 1 at AVF. Then, as you told in 4th decade, they can get the atrial arrhythmias. And in some of the ostium secondum ASD, there may be conduction block also. Okay. So these are all the ECG findings. RBB with right axis, left axis, the croquetage, splintering, then inverted P waves in 2-3 AVF in sinus venosus ASD, loss of sinus arrhythmia, counterclockwise and clockwise activation in these two types of ASDs, then arrhythmias, then blocks. So in the exam, if they ask all these, you should tell it. These are ECG findings. Next, what investigation you want to do?
Sir, echocardiography.
No. Basic.
Chest X-ray, sir.
Okay. Tell the X-ray findings.
So chest X-ray, there can be plethora.
Put the X-ray.
And then this.
Yeah, tell the X-ray findings.
This water jug handle appearance in ostium secundum ASD.
Yeah, before water jug, the common is LA to RA, the blood will come. RA to RA. What will happen to the pulmonary circulation? More blood or less blood here?
More blood.
So pulmonary plethora
will be there.
And then RA will be dilated or not?
RA will be dilated.
RV?
Both RA and RV will be dilated.
And pulmonary trunk also will be dilated.
Yes,
that is the next thing. Then you tell the water jug appearance.
Yes, sir. Water jug appearance where the handle of the jug is formed by dilated pulmonary artery.
What you mark 3, the 3 number, that is the handle of the jug, right pulmonary artery. Right pulmonary artery. That is the water jug handle. Where superior vena cava will get enlarged? In which ASD? SVC?
Sir, sinus venosus ASD.
Why? The pulmonary veins normally should drain into all the 4 pulmonary veins should drain into the left atria.
Yes, sir.
Okay. In a sinus venosus ASD, one important thing is 90% of the sinus venosus ASD will have an abnormal connection. Okay. They won't drain into the LA. They will drain into either superior vena cava or RA.
Or inferior.
Or inferior also. Superior vena cava, RA or inferior vena cava. Suppose if they drain into superior vena cava, then you get an enlarged superior vena cava.
Okay, sir.
90% of the sinus venosus ASD will have this anomalous venous connection. Partial anomalous venous connection. Partial. The 2 will drain into LA only. The other 2 pulmonary veins will either drain into superior vena cava or RA or even RV or inferior vena cava also. That we'll discuss inferior vena cava. If it drains what it is, we'll discuss that later.
Okay.
So superior vena cava will be dilated. Okay. What is Smithard syndrome?
So right pulmonary veins draining into
the
inferior vena cava.
Yeah, tell that.
So this characteristic sword-like appearance, this is due to the drainage of right pulmonary veins directly into the inferior vena cava.
So right pulmonary veins into inferior vena cava associated with the ipsilateral lung hypoplasia.
Right lung hypoplasia will be there.
And ipsilateral pulmonary trunk also will be hypoplastic.
Yes.
Okay, so this is an important question. They may ask if you get a ASD case, Smithard syndrome.
Yes.
What is hilar dance?
Sir, hilar dance, it is a finding which is seen on fluoroscopy. It is characteristic of ASD. And
not only ASD,
even
you can get any left right shunt because more blood in
because
the
of pulmonary artery pulsations.
Characteristically seen in ASD.
Yes.
It has in ASD, VSD or PDA. Okay. Yeah. So these are the basic investigation, ECG and X-ray you have to do in a case of ASD. Okay.
Yes,
next, we can move with the higher investigation. What do you want to clean the diagnosis to confirm it?
Echocardiography can be done.
Which view you will do for ASD?
Subcostal view is usually preferred, sir.
Where you do TE?
Transesophageal echo in case of
which ASD?
Sinus venosus ASD.
You do a transesophageal echocardiogram.
Yes.
Okay. Yeah. So that's about the echocardiogram. Okay. So this is the investigation. Echo will clean the diagnosis. There is no further investigation required. Echo will clean the diagnosis. Okay. So if you get a case of ASD, a few points I want to discuss. Can you tell the difference between partial anomalous pulmonary venous connection and drainage? See, partial anomalous pulmonary venous connection means the pulmonary veins, instead of draining into LA, they will drain into RA. Partial, only 2 pulmonary veins. Other 2 will drain into LA only. Drainage means they will drain to the LA only, but at the rim of the septum. At the junction between the septum and the LA, they will drain. Normally only to LA. Because they are draining at the rim of the septum, some blood will drain into the RA. Instead of LA, the pulmonary vein blood, because leakage, it just leaks into the RA. That is the difference between pulmonary partial anomalous pulmonary venous connection and drainage. Then Smithard syndrome, they'll ask, I discussed that. Then fetal circulation, will it get altered in ASD?
It will not get altered.
Because in fetus, the circulation is through the patent foramen oval from RA to LA. So it just get affected by ASD, fetal circulation. Okay, right. Then now, in a case of ASD, if they develop older and older, what will happen? In old age,
Pulmonary, yes, sir.
in old age,
Increased risk of pulmonary hypertension.
one then LV dysfunction they develop, systemic hypertension,
Yes, sir. Systemic hypertension,
IHA,
aortic sclerosis.
cirrhosis. So that all will increase the LV diastolic dysfunction. So more shunt from LA to RA.
LA to RA. Yes, sir.
So they deteriorate as they become old age. They deteriorate ASD patients. Okay. Then in the atrial septal defect, the LV end diastolic volume, stroke volume, EF, cardiac output, everything will be reduced.
Yes, sir.
It's common sense because less blood is entering the LV. Everything reduces. Any effect on the coronary reserve in ASD? Can coronary circulation can be affected in ASD?
Coronary reserve will be reduced, sir. This enlarged right pulmonary artery can compress the left main stem coronary artery.
Yeah, the more blood in the pulmonary trunk, the more blood in the pulmonary trunk can compress in the left main, producing reduced coronary reserve. Okay, right. Here you asked in the history the orthodexia and platypnea. That may be relevant in this case. How?
Sir, patent foramen ovale.
Can you tell a few points about patent foramen ovale? How many percent it is seen?
Sir, it is seen in 25% and it is a normal variant.
So, what complication they can develop because of patent foramen ovale?
Sir, TIAs they can have. Then thromboembolism.
The paradoxical embolism.
Paradoxical embolism. Yes.
From the leg, the embolism can go to right side, from right side to left side. Paradoxical embolism they can develop.
Yes, sir.
Right. Yes. Okay. Then, as we discussed, infiltrative endocarditis is very rare in atrial septal defect. Okay. Then there are some few combination of the ASD which you should know. What is Luton-Becker syndrome?
Sir, Luton-Becker syndrome is ASD along with acquired mitral stenosis. That mitral stenosis
congenital ASD,
congenital ASD,
acquired MS. Can you tell what happens? So what
usually
happens
due
if
to rheumatic etiology.
Rheumatic etiology. So what happens if there is a common? See, normally ASD is more common in females.
Yes, sir.
MS is also more common in females. So Luton-Becker is still very much more common in females. If it is a very small restrictive ASD, it behaves like MS only. If it's a non-restrictive ASD, you will get a prominent A wave in JVP.
Okay.
Here, the pulmonary congestion doesn't occur because LA, even if it is contract against the stenosed valve, the blood will come to the RA instead of going back pulmonary way to the cut. So there won't be any congestion, even in X-ray also, in Luton-Becker syndrome. Okay. So can you tell us a few points about common atrium?
Common atrium can be associated with this. The syndromic association is there.
Ellis-Van Creveld.
Ellis-Van Creveld syndrome.
Common atrium. So they'll have a cyanosis, common atrium. It presents in the since childhood only. Okay. So it behaves like a ostium primum ASD in ECG. So they will have the RVBB with left axis deviation, splintering of the SVFs in 2-3 AVF with counterclockwise rotation with QV in lead 1 and AVF. They can have common atrium. So they'll have cyanosis. Then one important thing here is ostium primum ASD. It's a 5% incidence. So what other lesion will be there in ostium primum ASD?
So mitral regurgitation can be associated
because of the cleft mitral valve.
Cleft mitral plate.
So you get a pansystolic murmur in a mitral area, which will radiate to the base of the heart. And there can be infective endocarditis because of the mitral regurgitation.
Yes, sir.
Because MR is there, you get a V wave in JVP. Because of mitral regurgitation, you get a V wave in JVP. So here RBBB with left axis deviation, ostium primum ASD, splintering of the SVFs in 2-3 AVF, counterclockwise rotation with Q wave in lead 1 and AVF. Will be there in the ECG findings. Okay. So that is about ostium primum ASD. Then after discussing all these, first you should know what to do with the patient. Okay, if you get a patient. Okay, what are the indications of surgery?
So indications for surgery, we have to see the ratio of pulmonary to systemic flow. That should be more than 1.5:1. Then there is a definite indication for surgery.
If you operate before 25 years or the pulmonary artery
and prognosis less than 40 mmHg, they have a good prognosis. Yes,
what is the contraindication to surgery?
Contraindication is when the patient is having pulmonary hypertension.
Pulmonary
and the reversal of shunt.
It should be very high. With the reversal of shunt, with SpO2 less than 90%, then you should not operate. Then if you operate, then the RV will fail immediately. You should not operate. That's why, as a physician, your duty, if you find a ESD patient, you have to immediately refer for a echo if the flow is more, better to operate it. You should not allow them to go for a ECM measure, because nothing can be done once they go for a ECM measure. Their life will spoil. So as a physician, you have a duty to refer to a surgeon.
Cardiologist.
So if ostium secondum ASD, how do they close?
Sir, ostium secondum ASD usually device closure
Device
can be
closure.
done.
No, for sinus venosus ASD?
Sinus venosus ASD usually closed by open procedure.
Yeah, so cardiac surgery, open heart surgery,
Cardiac
they do for
surgery.
sinus venosus ASD. Okay, right. What is the ideal age of surgery?
So 2 to 4 years is the ideal age for surgery.
Okay, correct. Right. So what is the common cause of death in atrial septal defect?
Death, cardiac failure can be the most common cause.
Most common cause is cardiac failure.
Yes.
Okay, right. Okay, what is pentology of Fallet?
The pentology of Fallet, tetralogy of Fallet associated with ostium secondum ASD.
Is pentology of Fallet.
Yes, sir.
Right. So these are some of the questions which they can ask if you get a ASD case, your clinical findings and the investigation.
Yes.
You have done very well. Almost all the questions you
Okay.
answered, nicely prepared.
Thank you, sir.
Yeah, good. Nice. Okay.